Welcome to this special four-part series of Diabetes Core Update, where we've been discussing obstructive sleep apnea. This is important because the prevalence of OSA has increased dramatically over the last 30 years. It is closely linked to obesity, and it's common in people with diabetes. And it has many consequences. Those consequences include reduced quality of life, difficult to control hypertension, impaired blood glucose control, and an increased rate of heart failure, MI, and stroke. It's also important for us to understand that by all estimates, it's quite underdiagnosed. We're seeing it often in the office, and we're not realizing it when we're seeing it. I'm your host, Dr. Neil Skolnik, professor of family and community medicine at the Sidney Kimmel Medical College of Thomas Jefferson University. This special series of Diabetes Core Update is sponsored by Lilly. In the first episode, we focused on the basics of OSA. We discussed what it is, some of the underlying pathophysiology. We discussed epidemiology, how the severity is described, and the consequences. In the second episode, we focused on making the diagnosis and interpreting the results of sleep studies, and I'd really suggest take a listen carefully to that episode because there are some pearls of wisdom there. And in this third episode, we'll focus on treatment. And when it comes to treatment, there have been some important developments over the last few years and even just over the last year, and there's more to come. In the fourth episode, next month, we'll discuss some cases. Joining us, both for the second episode on diagnosis and today's episode on treatment, is Dr. Sanjay Patel. Dr. Patel is a professor of medicine, epidemiology, and clinical and translational science, and director of the Center for Sleep and Cardiovascular Outcomes Research, as well as the medical director of the Comprehensive Sleep Disorders Program at the University of Pittsburgh Medical Center. Welcome, Sanjay.
Thank you so much, Neil. It's great to be back with you.
Last episode, we talked about making the diagnosis and ordering sleep evaluations. Can you briefly remind us of when to order at-home sleep studies versus in the sleep lab sleep studies?
Sure. I think the easiest way to think about it is that home sleep testing works well to distinguish patients with obstructive sleep apnea from people with no sleep disordered breathing. It's cheap, quick, and simple, and most patients prefer it to an in-lab study. So it should be the go-to test if your only concern is obstructive sleep apnea. On the other hand, home sleep tests haven't been validated in general to distinguish obstructive from central sleep apnea or hypoventilation syndrome or nocturnal hypoxemia from COPD or other significant lung disease. So if the patient has risk factors for these less common forms of sleep disordered breathing, then an in-lab sleep study is probably preferred.
So that's so helpful, and that orients us. And so let's go on now to treatment. First, at what level of AHI do we think about treatment? And then I want to talk about the main categories of treatment.
Sure. So the definition of obstructive sleep apnea is really an AHI above 5 with symptoms or an AHI above 15. So those are the situations where we're thinking about treatment.
That's helpful. And then when we think about treatment, we can think about it with regard to certain categories. How do you conceptualize it?
Right. So I classify treatment options broadly into 5 categories. First, there are conservative measures that focus on improving sleep and reducing sleep apnea risk factors. Second is continuous positive airway pressure, or CPAP, and its variants like bilevel or BPAP. Third, there are dental or oral appliances. Fourth, there are surgical treatments that can include both upper airway and bariatric procedures. And finally, the newest treatment option is pharmacologic therapies, which right now focuses on tirzepatide.
So that's helpful. So let's jump in and talk about behavioral interventions. Can you tell us about what those interventions are and where they might fit in?
Yeah, so behavioral interventions should really be integrated into the care of all patients with sleep apnea. They might be the primary treatment option for people with mild symptoms who don't want to pursue more aggressive treatment, but they should also be included as adjunctive therapy for patients who have more significant symptoms. I divide behavioral interventions into 2 general categories: approaches to reduce sleep symptoms independent of the sleep apnea, and approaches that are aimed at reducing symptoms by reducing the sleep apnea severity. So if the patient's main complaint is feeling tired, then improving sleep hygiene by making sure the patient's getting on a regular sleep schedule with 8 hours set aside for sleep may reduce their symptoms of fatigue without any direct effect on sleep apnea. Similarly, if snoring is the major complaint, then treating allergies with antihistamines or nasal steroids or sinus irrigation and using nasal dilators can really help without affecting the sleep apnea. In terms of behavioral interventions that act by reducing sleep apnea severity, this can include cutting out alcohol close to bedtime, since alcohol, by relaxing muscle tone, exacerbates sleep apnea. Sleep apnea also tends to be worse when you're laying supine, because in that position, gravity pulls the tongue back into the throat. And so positional therapy that involves having the patient actively avoid sleeping on their back can help to reduce sleep apnea severity. That can be accomplished by creating a mechanical barrier. Classically, this involves sewing a tennis ball into the back of a pajama top, but it can also be accomplished by wearing a backpack or a foam cushion that makes it hard to roll onto your back. You can also use body pillows to narrow the space available on the bed between the edge of the bed and where you're sleeping, so there isn't enough room to roll onto your back. In addition to those mechanical solutions, there are also now electronic devices that you can wear which sense when you're lying supine and send vibrations or buzzes to wake you up and have you roll back onto your side. Diet and exercise can also help lower sleep apnea severity by causing weight loss. Independent of any weight loss, exercise itself can reduce sleep apnea severity. Exercise also helps people sleep more soundly at night and feel more energetic the next day, so it also helps reduce symptoms independent of any sleep apnea effect.
Yeah, I was reading an article recently about exercise and sleep apnea, and I was happily surprised to see that. And actually, there was a graded response with people who did more exercise having a greater effect on decreasing sleep apnea. Could you now touch on the form of therapy that I think most of us are most familiar, which is PAP therapy?
Sure. So continuous positive airway pressure, or CPAP, has been the mainstay of treating sleep apnea for over the past 40 years. Simply, it consists of a mask that's connected to a fan that blows air to generate a pressure. That pressure keeps the throat from collapsing, allowing the patient to breathe normally around the set pressure. The advantages of PAP therapy is that the treatment is 100% effective at treating obstructive sleep apnea. The problem is that it's not the easiest treatment to get comfortable using. Many patients are unwilling to wear CPAP, and others just have difficulty getting comfortable breathing with the mask on. It's not easily portable for people who don't sleep in the same place every night. It requires some maintenance, and there is a stigma attached to CPAP as it's frequently ridiculed in popular culture. So about 75 to 80% of patients will get the hang of CPAP and meet minimum adherence criteria at 3 months, but adherence slowly wanes over time, as it does with many chronic therapies. So by 2 years, only about 50% of patients are still using it.
That's interesting. I know a lot of my patients struggle with that. Initially, when they get their CPAP, they love it. They notice how much better they feel. And then whether it's months in or years in, sometimes they, seem to get tired of wearing it or just don't wear it as much because it's challenging. Speaking of challenging, is if we're thinking in primary care about ordering those home sleep studies, let's say we do in someone who we think might have sleep apnea and it comes back positive, the next step, of course, is ordering PAP therapy, which used to be very complicated. Can you talk about auto-titrating CPAP and whether that is actually implementable by physicians other than a very experienced sleep specialist?
Sure. As you said, Neil, in the past, if you wanted to start someone on CPAP, you would have to have them spend a night in the sleep lab with the technician slowly titrating the pressure applied by the CPAP to find the lowest pressure that eliminated the sleep apnea, what we call a CPAP titration study. Modern machines have these auto-titrating algorithms where the machine senses airflow and can adjust the pressure up and down to eliminate any obstruction. There are 3 main advantages of auto-titrating CPAP over using fixed pressures. First, with the auto-titrating CPAP, there's no longer a need for the patient to have to go back into the sleep lab for a titration study. As soon as you have a diagnosis, you can prescribe CPAP. Second is that prescribing the CPAP is simplified. You can just prescribe auto-titrating CPAP with a wide range, like 5 to 20 centimeters of water on every single patient, and then let the machine figure out the right settings for each patient. This makes it much easier for non-specialists to order CPAP for their patients because they're ordering the same settings for every patient. The third advantage is that there's no longer a need for close follow-up to adjust pressures. If a patient loses significant weight or develops heart failure or gets pregnant, the auto-titrating algorithm will automatically adjust their CPAP pressure without needing to reevaluate their requirements in the sleep lab.
So that's interesting, and we'll talk a little later about tirzepatide, but I imagine this becomes important when we prescribe weight-reducing treatment for people. If someone loses 50 pounds, their pressure need is going to change. So tell me if I'm correct here. This approach makes dual therapy, tirzepatide and CPAP, something that is implementable. Is that right?
That's right. The machine will just adjust the pressure to a lower setting as the patient loses weight, and so there isn't need for close follow-up until you get to a point where you might think that maybe their sleep apnea might be cured, in which case you might want to do another sleep test off the CPAP to see if they even need to use that anymore.
Okay, interesting and important. Now moving on to dental treatments. Tell us about dental treatments.
Sure. There are two main kinds of dental appliances or oral appliances for treating sleep apnea, what are called mandibular advancement devices and then tongue retaining devices. The evidence for tongue retaining devices is fairly poor, and so these are not typically covered by insurance and they're not generally recommended by most sleep specialists. The evidence really is focused on mandibular advancement devices, where there is a strong evidence base for effectively treating sleep apnea. These devices are made by a dentist to fit over your teeth like a retainer. They use the upper jaw as a fulcrum to move the lower jaw or mandible forward. This pulls the tongue forward and opens the back of the throat. To use a mandibular advancement device, you need to have adequate dentition because it's using your teeth to leverage your jaw. And so you typically need to have at least 4 good teeth in each quadrant. There's a limit to how far you can pull the mandible before it starts to hurt, typically causing TMJ-type pain. So the question really becomes whether you can pull the mandible enough to open the airway before it starts causing pain. People who are less obese and who have less severe sleep apnea tend to have better outcomes with the mandibular advancement device because they need less advancement of their mandible to open up the airway. The devices tend to be easier to use and more comfortable than CPAP. Comparative effectiveness studies have shown that symptom control in sleep apnea is about equal with CPAP and mandibular advancement devices because the CPAP tends to treat the sleep apnea better, but nightly usage is greater with the dental appliance. Besides TMJ pain, the major concern with the mandibular advancement device is that the forces applied on the teeth can cause the teeth to move or become loose, so regular follow-up with the dentist is recommended.
Okay, helpful. And how about surgical treatments?
Yeah, so there are a number of surgical options. For patients who have a lot of difficulty breathing through their nose, nasal septoplasty or sinus surgery may be useful to help open up the nose. This can reduce snoring and can make CPAP more tolerable, but these procedures themselves don't really treat the sleep apnea. Historically, uvulopalatal or UPPP has been the most common surgery used to treat sleep apnea. However, recent data shows this procedure has a lower success rate than originally thought, and even when there is an initial cure, there's a high relapse rate over time. As a result, this procedure has really fallen out of favor as a sleep apnea treatment. Nowadays, the most common surgical treatment is hypoglossal nerve stimulation. This involves the placement of a pacemaker onto the hypoglossal nerve on one side. The pacemaker gets turned on when the patient goes to sleep with the remote control, and it activates the genioglossus muscle in sync with breathing to pull the tongue forward and open up the airway. In patients who are not severely obese and whose throat collapses in the right way, this treatment can work in about 80% of patients and is a reasonable treatment option in patients who have significant sleep apnea and have failed both CPAP and a dental appliance. There are a few additional surgical options in subsets of patients. In children, adenotonsillectomy is first-line treatment for sleep apnea, and even in young adults in their late teens or early 20s who have very large tonsils and not much obesity, this may be a curative option to consider. For patients, again, who are not obese with significant retinopathy as their main risk factor, maxillomandibular advancement surgery can be curative in over 90% of patients. However, this surgery is fairly morbid. It involves breaking both the maxilla and mandible and resetting those bones forward to open up the airway. It requires people generally to be out of work for about a month as their jaw heals. And so it requires them to have family members who can help take care of them through that time. Finally, bariatric surgery is a viable treatment option for sleep apnea patients who have severe obesity. We know that you need about a 15% reduction in weight to get a clinically important improvement in sleep apnea, and bariatric surgery can certainly provide that degree of weight reduction.
And it's interesting, mentioning weight, of course, the newest treatment on the block is tirzepatide, and the SURMOUNT OSA study, I remember, came out almost exactly a year ago. It was June of 24 that it was announced at the ADA meeting, and it was FDA approved, I believe, this past December of 24. Can you tell us about tirzepatide and its place in treatment?
Yeah, the approval of tirzepatide for obstructive sleep apnea has been very exciting for the sleep apnea community and giving patients another treatment option. Again, we know that obesity is one of the strongest risk factors for obstructive sleep apnea, and the FDA has approved the use of tirzepatide for patients with moderate to severe obstructive sleep apnea of a BMI of 30 or more. By helping patients lose weight, the apnea-hypopnea index, or AHI, fell by about 50% in the two clinical trials that were reported in the SURMOUNT OSA study, where patients were on 10 to 15 milligrams of tirzepatide per week. Besides large reductions in weight, patients had a large reduction in blood pressure that outstripped any effects seen with CPAP, dental appliances, or upper airway focused surgeries. In contrast, the degree of improvement in sleep apnea symptoms was less impressive with tirzepatide in those studies. This may be because patients in those trials were recruited primarily from weight loss rather than sleep clinics, and so didn't have large sleep symptom burdens to begin with. In addition, one of the trials focused on people who are already using CPAP, and in that trial, the symptom improvement was even smaller, again, suggesting that there may not be greater added benefit in patients who already have their sleep apnea optimally treated with CPAP. In terms of how this is going to pan out in sort of real-world sleep medicine clinics, we really need more real-world data to get a good assessment of how well tirzepatide is going to work as a symptom-reducing treatment. But for now, it is pretty clear that there's big blood pressure effects, and we already know from, broader studies that there are huge metabolic effects, improvements with treating patients with tirzepatide. And so for patients who are interested in treating their sleep apnea as a way to reduce their cardiometabolic risk, tirzepatide really seems to be a great option.
Yeah, I was at that meeting where SURMOUNT OSA was presented, and the endpoint that stood out to me, there was a secondary endpoint that was, I believe, an AHI less than 5 or 5 to 15 with a negative Epworth sleep score, meaning people weren't tired during the day. And they looked at that because that's the level at which often CPAP wouldn't be prescribed. And I think that was reached by about 50% of the group, at least in the non-CPAP group.
Yeah, that outcome is sort of an older outcome in the sleep apnea literature in terms of indications for treating. The move for indications for treating is really pushed less about the AHI and more about symptom control. Mm-hmm. And so I think it's a little bit difficult with the population in that trial because the symptoms were not severe in most of those patients, again, because they were recruited from weight loss clinics primarily rather than sleep clinics. And so how to use those data in patients who come to sleep clinics, I think, is still not completely clear.
Okay, that's really helpful. And it's going to be interesting to see how this all plays out over time, whether it'll be driven partly by patient preference, partly by, as you said, need to address metabolic and weight-related outcomes in addition to sleep outcomes. Sanjay, I just want to thank you for taking the time to go over all the different aspects of treatment in such detail. And in our next podcast, we're going to try and bring together some of those tough decisions in the context of cases. So really, thanks for joining us. We're about out of time. Before we end, do you have any final thoughts you'd like to share with our listeners?
Yeah, I think you made a really good point, Neil, that I just want to emphasize is a lot of these treatment decisions really need to be driven by patient preference. And it's important to make clear to our patients that treating sleep apnea doesn't involve just CPAP anymore. There are many different options available. And while CPAP may be still the best option for many people, if someone can't use CPAP or doesn't want to use CPAP, there are multiple other options we should discuss with them, including tirzepatide as the newest kid on the block.
Thanks so much, Dr. Sanjay Patel. Thank you for joining us.
Thank you.
And most of all, as always, thanks to our listeners. Thank you for joining us on this third of a multi-part series on obstructive sleep apnea. In the first part of the series, we focused on the basics. In the second episode, we focused on diagnosis and interpreting the results of sleep studies. And in this episode, we reviewed treatment options. In our next episode, we're going to look at some challenging cases to bring it all together. This special episode of Diabetes Core Update is sponsored by Lilly. We thank you for listening. For the American Diabetes Association, I'm Dr. Neil Skolnik. Till next time, stay safe and keep learning.